So next is axillary management in the breast surgery. It's V2. How do you manage the axilla in women with invasive breast cancer? So axillary status means vital importance for providing prognostic information and guiding the adjuvant treatment. We have to complete a pre or triple assessment, clinical examination, imaging, FNAC or core biopsy finding suspicion node. Ultrasound provides the best assessment of the axillary lymph node. All patients with invasive breast cancer should have prior to axillary examination and biopsy if indicated. Ultrasound feature of the suspicious node include round rather than elliptical shape, increased size, absence of fatty myelin, and thickened irregular eccentric cortex measuring more than 3 mm. So positive FNAC or core for lymph node mets, high level of suspicion indication for the primary node clearance. Clinical radiology node negative would indicate a sentinel node biopsy. Overall, 10 years survival is 75% for node negative patient and 25-30% for node positive patient. What is the role to support the use of sentinel node biopsy? It's in Cardiff 2006 they did the Almanac trial and they used radioisotope and blue dye to locate the sentinel lymph node. Are you aware of an intraoperative method of assessment of sentinel node and how will you this affect the patient management? Yes, frozen section, TIC, that's touch imprint cytology, and OSNA, which check the PCR performed for epithelial cytokeratin. And what is your opinion on the management of axilla on the discovery of positive sentinel lymph node? So there are 3 degrees of positivity: macromet, that's more than 2 mm, or micromet, less than 2 mm, and isolated tumor cells. So isolated tumor cells and macromets, they are not considered a threshold for clinical adjuvant treatment, but macromets more than 2 mm, they are considered positive. Then the patient can be offered either radiotherapy or axillary clearance or leave alone for with adjuvant treatment. So there are different trials for that. And positive sentinel lymph node plus one axillary node. So there's majority patient with preoperative clinical and radially node negative axilla and positive sentinel node are being over-treated by axillary clearance and have the long-term potential morbidity of lymphedema. Current guidelines state that a combination axillary node clearance is recommended in patients with 3 or more sentinel node macromets more than 2 mm. For these patients with 1 to 2 nodes containing macromets who are postmenopausal T1 grade 1 2 ER positive hardcore tumor who are receiving best consideration with whole breast radiotherapy patient are fit for further options or for further axillary treatment or either into Polnock trial. For patient with isolated tumor cells and macromets, no further axillary clearance. Are you aware of any trials that further investigating management of axilla? So these are the trials. So we are not going into the trials. Thank you.